You are listening to the Horse Radio Network, part of the Equine Network family.
Hello and welcome to this episode of the Disease Du Jour podcast. I'm your host, Carly Sisson, and in this episode, I spoke with Dr. Alvaro Bonilla about arthroscopy in horses. The Disease Du Jour podcast is brought to you by Merck Animal Health. Dr. Bonilla obtained his veterinary degree in 2005 from the University of Cordoba in Spain. Afterwards, he completed internships in Spain and Canada and an orthopedic research fellowship at the University of Pennsylvania. After this training, he went to The Ohio State University, where he obtained a Master of Science focusing on the stifle and subchondral cystic lesions, at the same time that he completed an equine surgical residency. In February 2015, he became a diplomate of the American College of Veterinary Surgeons. After finishing his residency, he stayed at The Ohio State University as an emergency and surgery clinical instructor before joining the surgery team at the University of Montreal in 2016. There, he developed a research lab in clinically applicable and minimally invasive surgery that led to many publications regarding standing arthroscopy and minimally invasive procedures. In 2023, he moved back to the U.S. to join Tennessee Equine Hospital, where he now offers his services. Thank you, Dr. Bonilla, for joining us today.
Thank you for the invite. I'm glad to be here.
Can you get us started by explaining the difference between arthroscopy versus bursoscopy or tenoscopy, and what are some of the different types of arthroscopies?
Yeah, so arthroscopy is a general term for a keyhole procedure. So basically, through a small incision, you will put a rigid endoscope that most of the time is a 4 millimeter scope. And then arthroscopy is the term for the technique when you do this within a joint. Most joints, they have two bones involved, but there are others with multiple bones, like, for example, the carpus. And then the tenoscopy, bursoscopy is pretty much the same procedure, but you will do it on a tendon sheath for tenoscopy. A tendon sheath is just a synovial structure like a joint, but rather than having bones, you have tendons. And the structure goes completely around the tendons, like, for example, the digital tendon sheath at the level of the fetlock. And a bursa, where you will do bursoscopy, is basically a synovial structure between a tendon and a bony surface. So the goal of that synovial structure is to provide a gliding surface or lubrify the movement between a tendon and a hard bone. For example, the navicular bursa, where you have the deep distal flexor tendon rubbing or gliding at the back of the navicular bone. So in all of them, you will put a camera in there, a camera into the joint, and then replace the synovial fluid that is yellowish in color by a transparent media. Most of the time, that will be transparent fluid, isotonic fluids, or in some cases, you could do it with gas arthroscopy, which is something that we do as well, maybe not as commonly as just putting fluid. The goal of putting fluid in there is, one is to have a transparent structure so you can see through it very easily. And the second reason is because you will distend the synovial structure, so that way you can move around a little easier. I guess I'll answer the second part of your question. So the type of arthroscopies, tenoscopies, or bursoscopy, you can divide them basically into two types. Diagnostic arthroscopy. In diagnostic arthroscopy, you basically go into that joint or synovial structure just to try to find the source of pain, lameness, distension. Versus a therapeutic arthroscopy is when you already know the problem before getting into that joint and you go directly to address it. Not to say that sometimes a procedure may start being diagnostic, and during that procedure you find the source of the problem, and then it becomes therapeutic halfway of the procedure.
So what are some of the conditions that arthroscopy is commonly used to treat? I know probably OCD fragments would be one, and are there any other pathologies?
Yeah, I would say OCD fragment is the number one reason why we do arthroscopy. and OCD is just little fragments that form into the joint while the horse is developing. So the bones around the joint, they are actually cartilage, and over time they ossify. And sometimes for different reasons, there can be a problem with that ossification, and they form those OCD fragments. The hock, the stifle, and the fetlock are the most common regions where you will have that. And I would say the bulk part or the simplest arthroscopic procedures are to remove OCD fragments. And then you will have many others that they are traumatic fragments, either from a single trauma or, for example, in race horses from repetitive trauma. And those one will be the typical chip in the dorsal aspect of the fetlock, or we call it dorsoproximal P1 fragments, some fragments from the sesamoid, all those small fragments in race horses that you will have in the carpus. So all those are articular fragments. And then, as we already talked about tendon sheath and burses, you also have a number of soft tissue injuries that you can address, because through the joints and tendon sheath, you also have soft tissues, joint capsule, tendons. So those tendons can have tears. So there are a multitude of soft tissue problems that you can address, from tendon injuries to ligament tears to meniscal problems. You can also address cartilage problems, which in the joint not having a fragment, you can have cartilage abnormalities that sometimes can be addressed surgically, sometimes can be addressed with medical treatments. And I will say those, are the most common things. And then arthroscopy has progressed over time, and now we use it for other things, like assisting us to do better fracture repair when a fracture occurs within a joint, for example.
What are some of the diagnostic techniques you would perform prior to going to arthroscopy?
Yeah, I would say even though technology has advanced quite a bit, for most of the problems, the basic diagnostic tools are still radiography. So you have to remember, with radiography, you see the main areas of a joint, but not a joint completely. So radiography is still probably the most commonly used technique to diagnose fragmentation within a joint. But when despite it's very commonly used, ultrasound, it has evolved over time, and the use, it has progressed and is really commonplace. And some studies have already revealed that for many areas, ultrasound is actually more sensitive than radiography. Yes, with a radiograph, you will see the fragment per se very clearly, but ultrasound in some areas is even better. I use it very commonly, for example, for fetlock fragments, that you find it all the time, where they're very typical to see them, especially on the dorsal part with radiography. Ultrasound is actually more sensitive to find those fragments, to know the size, to know how many. So radiography and ultrasound for sure are the most commonly performed techniques. And then you will go into other advanced diagnostic techniques that, thankfully, with the progress of technology, are becoming more commonplace, like CT, MRI, and another tool is a standing needle arthroscopy that we'll talk about it hopefully later. So there are other techniques that can help you before you decide to perform this procedure.
And I know that arthroscopy is oftentimes performed alongside ultrasound. So can you explain that process a little bit, and how ultrasound helps guide these procedures?
Yeah. So as I said, as we are advancing and becoming more comfortable with the use of ultrasound and knowing more about arthroscopy, we continue, even though arthroscopy has been around for humans over 100 years, in horses, starting in the 70s and the 80s. So it hasn't been around for that long. And, I was trained by the first people that started using arthroscopy. So sort of two generations. And now arthroscopy is the gold standard. But we keep advancing. And there are some times that you will have fragments that can get covered by synovium, that can be in little corners of the joint that they are difficult to identify. You can also have some foreign material or foreign bodies that sometimes they can be difficult to detect. So ultrasound is extremely useful in those occasions, and it's very easy. You basically, while you are doing your procedure, you just put a sterile cover on your probe, and then you can detect that little fragment that may be looking right away you don't see. You mark it, for example, with a needle, and then you know exactly what area you have to go. So it's something that I wouldn't say you have to use it every day, but once in a while, it's extremely useful for those fragments that they are hard to find, or those foreign bodies that sometimes they're even in the middle of a tendon, and unless you use ultrasound, you will be fishing around. So extremely useful technique for difficult structures to find.
Today's Disease Du Jour podcast is brought to you by Merck Animal Health's Protozil 1.56% diclazerol anti-protozoal pellets. Get the scoop on Protozil easy-to-administer top-dress alfalfa pellets, a safe and effective treatment that starts working fast without a loading dose. Learn more at merckanimalhealthusa.com. Do not use Protozil in horses with known hypersensitivity to diclazerol. Safety has not been studied in breeding, pregnant, or lactating horses. For complete safety information, please read label. So at what point do you recommend performing arthroscopy, and do you find it important even in asymptomatic horses?
Yeah, great question. And I think there is still a lot of confusion, especially with general practitioners. And I think for us as surgeons is very important to do some coaching in that regard. And, even sometimes there is some disagreement in between surgeons of what fragments they need to be removed and which ones you shouldn't. I will say, I will say probably more than 90% of the fragments need to be removed. It is true that some fragments, they will occur. The horse will have a flare, inflammation in the joint, and then that will subside relatively quickly. And you will see that the lamina goes away and the horse is comfortable. If you are looking at the short-term prognosis, you probably can go ahead and raise that horse. And I'm talking about a small dorsoproximal P1 fragments, some small OCD lesions. But I will tell you, over the years, I've dealt with many fetlock fragments that the owners have not removed right away, or they have been recommended to wait because they weren't symptomatic at that point. But there is not just my personal experience. There are several studies that have shown that those fragments, and almost all the fragments into the joint, they will produce synovitis that will damage the cartilage over time because of the inflammation, or they will wrap slowly in the cartilage and you will have wear lines. So there will be long-term consequences. So I explain this to clients. My job is not to consider this horse is sound for a week or a month. My goal is to provide clients with a healthy horse for many years. And with that purpose in mind, most of the fragments, not all of them, but most of the fragments, I do recommend to remove them. Another example, during COVID, we got a huge backlog of surgeries, and they were just simple OCD fragments, just the typical bogey hog without consequence. But I got into some of those joints later than average, which I will get into then when they are yearlings or so. And many of those fragments, from not being addressed quickly, they got detached from the joint and produce a lot of damage into those joints. When those fragments, they get detached, and it's extremely difficult to determine when a fragment is going to detach from the attachments or not. They will be in the joint sort of like a blender. Sometimes there was a fragment and they disappear because they get destroyed. But the consequence of having it free in the joint, rubbing everywhere, is that they are going to produce quite a bit of cartilage damage. So during COVID, I saw many horses with free fragments that usually I won't see so many, that even though they were young, they were already having quite a bit of cartilage damage that over time they will develop laminitis and arthritis. So as I said, asymptomatic is a word that is used very often for many fragments, and none of us like to be too invasive. And sometimes I will tell clients this almost like a prophylactic surgery. I know there are no signs right now, but over time, these fragments will produce damage to the joint. So it's something that it's important to bear in mind. Even though the horse doesn't have clinical symptoms, they will develop some signs over time. And it's probably in most occasions a good idea to do that sort of prophylactic surgery.
Yeah, that's a great point. What are some other applications besides fragment removal? I know we touched earlier about fracture repair, so can you explain how you perform that?
Yeah. So other than the common techniques that we use, probably for the last 20 years or so, assisted fracture repair is being used and progressively more and more commonly. So if you imagine, it's mainly for fractures that occur in racehorses for the most part, but can be seen also in other breeds. But they have two pieces of bone within the joint, which radiographically you will try to put together perfectly in perfect alignment. But what you think radiographically is in perfect alignment, when you do have a camera and you're looking into the joint, that may be 1 to 2 millimeters off. And for an athlete like a racehorse, 1 to 2 millimeters off in that alignment that you may not perceive with radiographs and you may think is perfect, is actually the difference between having an athlete continue to perform or having to retire a horse. So in some cases, when you have those complete fractures, you can assist while you are repairing it with your camera into the joint to obtain perfect alignment. And not only to obtain, is also very useful for prognosis, because if you don't get your eyes in there, you don't know, as the consequence of the fracture, if you have multiple little fragments, if you have a lot of cartilage damage. So it can help you in two ways: to give a better prognosis for that athlete, help as well on the rehabilitation, and also to obtain the best alignment as possible.
Now, I know you have a lot of experience with minimally invasive techniques, so can you explain the benefits of standing procedures over more common methods and some of the equipment required to perform that?
Yeah, thank you for that question. So the bulk of my research has been about minimally invasive techniques and developing some of them, and also about developing standing procedures. So there are kind of 2 points to address here. Minimally invasive techniques refers to mainly all those techniques where you make a smaller incision. For example, and before the 70s and the 80s, you will do an arthrotomy, a larger incision, and remove that fragment. But the complications and the morbidity associated to that procedure significantly reduced when we started doing arthroscopy. And as I said, arthroscopy is definitely the gold standard. There is probably nobody now making arthrotomies to remove fragments from the joint. So minimally invasive techniques reduce the morbidity and speed up the rehabilitation process. So those horses or the joint can start moving and going back to exercise much faster. On top of that, you have standing procedures, which we have done some research about that in terms of, for how long they have been around, what's the trends between surgeons in the last, few years. I published with one of my residents a survey about these. Well, we sent a survey to all the American and European surgeons. And it turns out that, we found a significant change or a significant trend in the last 10 years as surgeons are becoming more and more familiar, and it's being more common to perform standing procedures. Unfortunately, the procedures that they are a little bit more technically demanding, like arthroscopy or fracture repair, are still procedures that they are not very commonly performed by surgeons. In that survey, we found that only 18% of surgeons will perform standing arthroscopy. But the benefits of standing procedures and standing arthroscopy, one of them is, and I guess the main one, and that was also the main one by the respondents in that survey, is that you avoid general anesthesia. General anesthesia in humans and dogs, in most cases, is not a big deal. For us, that 500 kilo animals are standing up after the procedure, unfortunately, there are complications a little bit more often than other species. The mortality rate is around 1%, which you will think it's not that high. But then you have a morbidity rate that in some studies is as high as 18%. And in some breeds, like draft breeds, that they are even heavier than 500 kilos, is even higher. So avoiding general anesthesia is definitely a huge plus of many standing procedures. In some of them, you will need less personnel and less time. But you cannot forget one thing when you do standing procedures is that you need to make sure that the horse is going to be well behaved, and then your team, yourself, and your equipment is going to be safe. And that's also a big concern. When you do those standing procedures, you need people to be well trained and make sure that the animals will tolerate that. And to allow that, it's extremely important, the team. I always say the same. I never do an incision during a standing procedure until the person that is holding the horse tells me that, the horse is good to go and is properly sedated. Beside the sedation, the joint needs to be anesthetized, the skin needs to be desensitized. So there are several steps that you have to do to perform them. But personally, I'm very familiar with the standing arthroscopy, especially in the fetlock joint. And at this point, if you ask me, where do I think that I see the joint better, the front of the joint, I would say that for me, it's easier to do it standing than under general anesthesia, and probably faster for the entire procedure, preparing the animal, finishing. I don't have to wait for the animal to stand up. Having said that, it's definitely, a procedure where you need to be very, very confident with the technique, and you have to do it quickly. It's not something that you will go from beginner training to do a standing arthroscopy. But if you are very comfortable doing, for example, fetlock arthroscopy under general anesthesia, I will encourage people to try standing because it is definitely a good thing for the horse, and it's actually probably less demanding technically.
Do you recommend using stocks for that procedure, or do you find it's usually well tolerated enough that they can be loose and held?
I do prefer to do it inside the standing stocks. You never know what it can happen. So it really helps you putting them in the stocks, sometimes using also a head support so they can rest the head a little bit, so they're a little bit more stable. So I would say most people do this procedure in the stocks, and it's just a little safer, I guess, especially if the horse reacts for some reason. They're in the stocks. As I'm getting older, and most of these procedures, I'm actually on my knees. I think about my safety more and more. So I use sometimes a helmet. So there are different levels of safety that you have to consider.
Can you discuss wireless arthroscopy and what the future might look like as that technology continues to advance?
Yeah. So technology, it's kind of crazy because probably in the last 20 years, technology has advanced so much. I remember CT and MRI was not available for everyone, and it's lately becoming sort of commonplace, and most practices will have either CT or MRI or both, or you may not have a CT or an MRI too far from where you live. And in that sense, this technology for your phones, for everything, is becoming smaller and smaller. We don't talk too much about it, but arthroscopes now, in the last few years, we have what we call needle arthroscopy. So there are arthroscopes that they are the size of a needle, and I've done quite a bit of research for that. Those arthroscopes are mainly used in humans and in horses to do diagnostic arthroscopy. The advantage of those is that you can do it standing, and basically you put that little arthroscope that is the size of a needle inside the joint, take a look around and find what's the problem. And then most of the time you will have to either, address with whatever specific medical treatment you think you have to based on your diagnostics, or you may need to convert to a traditional arthroscopy under general anesthesia. But that's, a tool that it's becoming more and more common, especially in some regions like the stifle, where you cannot do very easily perform CT or MRI. And then as I was working with this technology, I got in touch with some MDs that developed what I believe was the first wireless arthroscope. I think there are a few models right now, but basically is an arthroscope where you won't have any cables. You don't need a cable for the camera, or you don't need a cable for the light. You will still need a cable or a fluid line to deliver the fluids. But the fact that you don't need cables, it makes that arthroscope really a tool that you can transport anywhere. MDs now, they use that in their office when they travel around, when they go to third world countries. In my personal hands, I use it to do laparoscopy, IVU, because you can also use those technologies to do laparoscopy. I've done, and now I started using all the standing arthroscopies using that technology. So that way, I don't really have to move the big tower that people have seen. I don't have to move that from the OR to the surgery room where I do a standing arthroscopy. I just move my wireless arthroscope and my computer. My computer becomes actually the screen where I see it. And that, as well, it's a great tool for, sometimes we have horses where you have to scope 4 or 5 joints, and you may not have 2 towers with the full equipment. So sometimes I get another surgeon on board, and then one is doing arthroscopy in a couple of joints, while the other one is using the wireless arthroscope. And that way you decrease substantially the amount of time the horse is under general anesthesia. So there is definitely some uses in horses. You could potentially do ambulatory surgery, but that will imply that you have a really clean place and a place to do it. So probably we are still far from doing a lot of that. But I think wireless arthroscopy is something that will probably use more and more, or at least as a complement of traditional arthroscopes.
Yeah, it sounds like it's going to make the procedure a lot more accessible to more horses moving forward. So that's
and the price is actually substantially cheaper than the typical arthroscopic tower. So it could make it more affordable for many people as well.
Oh, awesome. Do you have anything else you'd like to add on the topic before we wrap up?
I will say, I will encourage people to not be afraid about arthroscopy. In the right hands, arthroscopy is very unlikely that an arthroscopic procedure will make the problem of your horse worse. So it will definitely, in most cases, will improve it, or at least just leave it as it is if it's not fixable. With the standing arthroscopy, you don't have to go through anesthesia. That actually also, in many cases, decreases the price for clients. But it's an extremely safe procedure with very low risk of complications. Only about 1% of arthroscopic procedures will become infected. We get more and more concerned about antibiotic use. When I do a standing arthroscopies, I don't even use antibiotics, and I don't have problems with infection. So I will encourage everyone that have a horse with a fragment in their joint or a fusive synovial structure, that arthroscopy may help that horse to not be afraid and get in touch with a surgeon that could help to get some answers for that, or to have that fragment removed before it becomes problematic.
Great. Well, thank you so much, Dr. Bonilla, for joining us. I think this was a really insightful conversation. And thank you so much to our audience for listening. And a very special thank you to our sponsor, Merck Animal Health, for allowing us to have these conversations. If you have any questions, suggestions, or feedback for the podcast, please send me an email at csisson@equinenetwork.com.